injuries often not being isolated to one or two cases, but having enough cases for it to be seen as a mass casualty event that will often overwhelm these already fragile health systems. And as recently published by the World Health Organization, there have been more burns injuries increasing globally, with various factors impacting those: conflict, displacement, industrial hazards. We have also, though, seen with a large increase in the way burns patients are treated and a lot more positive impact. There has been a shift from mortality to mobility in these patients. And as these survival rates improve, the focus of care must also shift to the recovery of patients, advocating for the vital role rehabilitation and all the professionals involved play in burns care. So just to re-emphasize that rehabilitation is not an afterthought and does need to start from day one. But before we do delve into what rehabilitation offers in burns patients, we must understand the burns injuries and their medical management in conflict. So I will first hand over to Professor Potokar to lead us into this presentation.
Thank you very much, Gaelle, and good evening, good morning, good afternoon to everyone who's attending this webinar. I obviously can't see you, but I'm very glad that you've made the effort to come and join this webinar. I'm just going to give a brief introduction to the medical care of patients with burn injuries in conflict. And really, this is obviously a huge topic, so with very little time, I'm not going to go into great details, but what I really want to do is get across some of the key principles around optimizing the outcomes for patients. So really the best way to start looking at this is to think about what does affect the outcomes in a patient with a burn injury. And really there's three main contributory factors. One is the patient themselves, another is the context, and the third is the injury itself. Next slide, please, David. So if we think about the patient factors, these are really quite straightforward, but we need to think about the age of the patient. Extremes of age tend to worsen the outcome in burns. We need to think about any significant medical history, so whether they're suffering from a chronic medical condition such as diabetes or high blood pressure or cancer or infectious diseases, etc., but also whether they're anemic or whether they have malnutrition. Any medication history, so pharmacological history, because certain drugs can impact on the outcome, such as steroids would be one example. And then obviously the social history, what the patient's family support is, what their home background is. Do they have a home to actually go to, which in conflict scenarios is not always the case. So these factors, these are the main ones, and underneath are many sub-factors, are what influence the outcome from the point of view of the patient themselves. Next. So then if we look at the injury factors, well, the classic ones are, of course, the extent of the burn, the depth of the burn, and the site of the burn. And to this, we must add associated injuries. And in conflict, whilst we can still get what I would call domestic burns or normal civilian type burn injuries, such as scald injuries in children, etc., but as we know from recent conflicts particularly, there is also a significant increase in direct trauma-related, conflict-related from principally blast injury. And this means that many patients will come with combined injuries. So in normal non-conflict scenarios, most burns are isolated burn injuries, whereas in conflict, a lot of them will be associated with other injuries. Now, these can be complicated blast injuries with extensive open fractures and shrapnel wounds, head, chest, abdominal wounds, etc., or they may be relatively simple, just a few shrapnel wounds, for example. Now, the extent, just to briefly talk about the extent of the burn is obviously important in influencing the outcome. But it's very difficult with burns because these 3 points, the extent, the depth, and the site, all interplay. So, for example, a burn that may be 30 or 40%, is that a serious or significant burn? Well, it doesn't just depend on the surface area, because if it's a deep burn, then it's certainly a very serious problem. However, if it's all entirely superficial, then that's much less of a problem and the outcome is likely to be much better. But it's not just the depth of the burn, because, for example, a 2-3% full thickness burn, is that in itself an indicator of the outcome? Well, then it also depends on the site of the burn. If that is in the middle of somebody's face and it's a full thickness burn, then clearly that is going to significantly impact on the overall outcome of that patient. Whereas if it's, for example, on the middle of the back or the thigh, it's going to have less influence on the overall outcome. So these are the injury factors, and I say the most significant of these that's different in conflict is the increase in associated injuries, particularly with respect to blast. Next. So perhaps the most significant difference in the impact in outcomes comes from the actual context. Now, some of these scenarios here and some of these points that I have listed here are typical in many low resource and fragile environments. So the main ones are the human resources. So in conflict, the human resources are often significantly reduced. This may be due to a whole host of issues. It may be due to people having fled the country, having been made refugees, having been displaced, borders and front lines crossing access to where a burn service may be, which means that the human resource is in the wrong place. There's lack of training in many places where there's conflict, but also during conflict, the amount of training and capacity building that can be delivered is significantly reduced. So for all these reasons, the human resources are reduced and will have an impact. Materials and equipment also significantly are going to be impacted. It depends again on the specific political situation, geopolitical and security situation, but there's inevitably a decrease in the amount of materials and equipment that are available to treat the burn. The physical infrastructure can be affected, and we've seen this recently, particularly in the last, let's say, 5 to 10 years. The health infrastructure being damaged and destroyed or disabled in one way or another, and particularly hospitals themselves, but also the pre-hospital system. The power supplies are often disrupted, which can have a number of effects. Obviously, that means that the sterilization of equipment can be made more difficult. Just simple things like the lighting and water supply can be affected, and this can clearly have an impact on the outcomes as well. Security is an obvious one, and this affects all stages, whether it's a pre-hospital or even in the hospital, and this in itself is linked to the access, so patients may find it very difficult to access whatever service is available. The number of patients often goes up dramatically, and they can arrive in large numbers from a mass casualty event, so this can then overwhelm the system. And the possibility of referring patients elsewhere also becomes extremely difficult, if not impossible. So all these, the context of conflict massively impacts on the overall outcome. Next, please. So what are the basic principles? Well, I think without going into the very technical details, we have learned that keeping it simple and keeping it safe is the key to getting good outcomes in these patients. And by that, we need to go back to the basic principles. What are we trying to achieve? And what we're trying to achieve is preventing infection, which is the main cause of complication and death if the patient survives the initial injury, and to promote the healing of the wound. And we want to do that whilst at the same time avoiding unnecessary complications. So those are the key basic principles. How do we do that? Well, if we briefly look at the three environments, the pre-hospital, the emergency room, and the hospital, we can see what we can do at each stage. Next. We'll look briefly at the point of injury and emergency room very briefly, and then just spend a couple of minutes on the hospital inpatient care. So at the point of injury, the key things are safe access, a rapid assessment of the patient, and again, because we're talking about conflict, that means catastrophic bleeding, airway, breathing, circulation, because these patients, as I say, often will have other injuries, and this is a case where scoop and run is the priority. So don't overstay and avoid unnecessary interventions at the scene, which is a highly dangerous environment, so you don't want to be hanging around. Next. In the emergency room, it's really, again, keeping it simple and straightforward, repeating the primary survey, doing a secondary survey. If the patient has arrived within 3 or 4 hours, still clean and cool the wound. Fluids, I'm not going to go into great detail, but basically a big burn over 20% needs some fluid. But the reality is that all the formulas, etc., are not that helpful because the staff aren't there to monitor the patients. There's also a lot of confusion about how much to give. So really, it's much more around just clinically keeping an eye on the patient. And if anything, it's better to give a little too less fluid than too much fluid. Standard things like tetanus tox, analgesia, etc., simple dressings, and then refer or transfer the patient if possible based on their clinical scenario. So the key things to avoid are antibiotics unless the associated injury requires it, because this will just lead to multi-resistant infections. To avoid fluid overload, which in this environment causes more problems than giving too little fluid. And initially avoid topical agents unless there's a long transfer, because this can make the wound more difficult to assess afterwards. Next. So finally, just the in-hospital care, as I say, this is where sticking to basic principles and keeping it simple and safe has the best outcome. This is not the environment for doing highly fancy surgery, whether that's complicated flap surgery or doing extensive excision and grafting of large surface areas very early on. That is completely out of place in the conflict environment. So really it's a question of doing dressings every 1 to 2 days under general anesthetic or sedation, debriding shrapnel wounds and delayed primary closure, so not closing these wounds initially. That leads to many, many problems. Alternating the topical agents, so betadine, flamazine, acetic acid or vinegar, these are all extremely effective and still effective today, topical agents. Mobilize the patient early, support their nutrition, and then as the patient recovers, it's doing staged grafting of the deeper areas. So it's a very different approach from how we would manage a single patient in a high resource environment. So avoid fancy techniques, avoid unnecessary antibiotics, don't skin graft too early, and do not close wounds primarily. So it's very much a safe and simple way to doing this, and we have seen personal experience from working in Gaza and in Lebanon that with this approach you can actually get really very good results. So that's all I'm going to say about the medical management, and I'll hand back to Gaelle now to hand over to David to continue with the rehabilitation side. Thank you.
That's great, thank you. Please just a quick word, so do ask your questions in the chat, even from both ends, so from what Tom has been saying and what David will go on to say.
Yes, thanks Gaelle, and thank you Tom for this quick introduction to burns and the medical side of things. Now I'll take you through